Hello, everyone, and welcome to our module on alcohol and CNS depressants. Let's start by talking about the DSM-5 definition of a substance use disorder. According to the DSM-5, a substance use disorder is two or more of the following during a 12-month period, and many of the things listed on this slide are obvious. For example, an individual who takes larger amounts of a substance over a longer period of time may have a substance use disorder. The same is true for all of these items listed here. But I just want to point out two features of these criteria, and those two features are tolerance and withdrawal. So a patient who withdraws, meaning they have symptoms when they stop using a substance, has a criteria for a substance use disorder. The same is true of a person who has become tolerant to a substance. If they are using more and more of it and they are becoming tolerant to the effects, then that person also has a criteria. Tolerance and withdrawal are two of the DSM-5 criteria for a substance use disorder, and you only need two or more during a 12-month period to meet the definition of this disorder. Also, for the Step 1 exam, they'll want you to know something about what's known as the stages of change. So when a patient quits abusing a substance, for example, quits using drugs or quits alcohol or quits smoking, the process that they go through to become clean is generally broken down into 5 stages. The first stage is called pre-contemplation. The last stage is the maintenance stage. And in between those two, there's contemplation, preparation, and action. And sometimes patients will remain clean in the maintenance phase. Other times they will relapse. So let's talk about what patients do when they're in each of these 5 stages. The pre-contemplation stage is when patients have no intention of behavior change and they may not even recognize or acknowledge the problem. So this is the case with many of the patients I see who smoke or sometimes drink alcohol. They don't think they have a problem. They think they can quit anytime, and they aren't willing to acknowledge the damage that it might be doing to their body. Many patients who are unable to stop using a substance are in this pre-contemplation phase, basically stuck in that phase. If they move out of pre-contemplation, they enter the contemplation phase. This is when they are aware the problem exists, but they're not yet willing to change. So I've also taken care of many patients who say, Dr. Ryan, I know I'm drinking too much and I need to stop, but I'm just not at a place in my life when I can do that. That's the contemplation stage. Next, they move into the preparation stage. This is where they intend to take action. So this is a patient who says, I want to quit smoking and I want to do it this year, or I want to stop drinking for my children or my wife and I want to do it in the next few months. These patients are in the preparation phase. After that, they move into the action phase where they actually quit using the substance, and then they move into the maintenance phase where they try to stay free of using the substance. And then, as I said before, some patients will relapse and go back to abusing the substance, unfortunately. So now let's talk about alcohol. When people talk about alcohol in terms of a substance of abuse, they are talking about ethyl alcohol or ethanol. This is its chemical structure on the screen here. It's found in alcoholic beverages like beer and wine, and it is a very commonly abused substance. It's metabolized by the liver and can cause liver damage, which I talk about in the GI section, and it has many biochemical effects on cells in the body, and I talk about these in the biochemistry section. What I'm going to focus on here in this video is the consequences of abusing alcohol and how patients try to quit using alcohol. Alcohol is a CNS depressant, so patients who are intoxicated with alcohol will have evidence of depressed CNS activity. So they often have slurred speech, incoordination, unsteady gait, and if they've really drinking too much, they can be stuporous or have coma. If you've ever seen anyone who's drunk, you know what it looks like when a patient is intoxicated with alcohol. The alcohol level in the blood is called the serum blood alcohol concentration, or the BAC. And in most US states, the legal limit for driving is 80 milligrams per deciliter. If you are caught driving and your blood alcohol level is higher than this, then you are guilty of drunken driving. Now, it's often not referred to in milligrams per deciliter. Instead, it's often referred to as 0.08 grams per deciliter, or sometimes just 0.08 or 8%. But whatever, this is the level that is the legal limit in most places in the United States. And the number of drinks it takes to reach the limit varies with a person's size. So you may know that small people can reach this limit very quickly. Larger people can sometimes consume more alcohol without reaching this limit. Occasionally, you will meet a patient in clinic who you suspect is drinking, but the patient may deny that they are drinking. And in these cases, there are some biomarkers you can test for which are evidence of heavy chronic alcohol use. These are all markers of liver damage, and they're used to screen for patients who may be heavy chronic users of alcohol. The first biomarker is GGT, which is gamma glutamyl transferase. It stays elevated in the blood until the patient has been abstinent from alcohol for 2 to 6 weeks. Another commonly used biomarker is AST, which is aspartate aminotransferase. It's one of the liver function tests, and it stays elevated in the blood until the patient has been abstinent for 7 days. In addition, it's very high yield to know for your board exams that patients who chronically abuse alcohol will have an increased MCV when you examine their red blood cells, and they often also have resistant hypertension. So if you're treating a patient for hypertension and they're not responding to the drugs, you should ask them how many alcoholic beverages they consume per day. If your blood alcohol content gets very, very high, this can depress the central nervous system so much that respiratory depression occurs, and this can be fatal. And when you work in the emergency room, unfortunately, you will sometimes see people brought in excessively intoxicated with alcohol, and some of them are basically in a life-threatening situation. The treatment is supportive. You just have to wait till the alcohol is metabolized and washes out of their system. Sometimes they require ICU care with mechanical ventilation, and as I said before, sometimes this can be fatal. Alcohol withdrawal is a very common problem that you'll see on clinical rotations in the emergency room and the hospital. This happens to heavy drinkers if they abruptly stop drinking and their body is accustomed to and needs the daily intake of alcohol. There are a series of physical changes that occur, and you need to know these for step one, so let's go through them now. So during the first day after the last drink, 6 to 24 hours after the last drink, the symptoms shown in this slide will occur. The main one is tremors, so patients who are alcoholics and aren't able to get a drink for whatever reason, after about 6 or 8 hours will start to have their hands shake. They will often feel anxious. They may have GI upset, headache, sweating, or palpitations. Importantly, though, their mental status remains intact. And when you see that the patient has intact mental status, that tells you that they are early on in the withdrawal process. Later on is when you can see mental status changes, which we'll talk about in a minute. Some patients with alcohol withdrawal can have seizures. This occurs within the first 2 days after the last drink. They're usually generalized tonic-clonic seizures, and they sometimes occur as just one seizure, but they often come in clusters of 2 or 3, and this can be a reason why someone is brought into the hospital, obviously. Alcoholics who are withdrawing also often hallucinate. This also happens within the first 2 days. They are often visual hallucinations. Sometimes they will see insects on their skin or animals. Sometimes they also hear voices. And some alcoholics have tactile sensations. A classic tactile hallucination is for the patient to feel like there are bugs crawling on their skin when their skin is normal. The most feared complication of alcohol withdrawal is called delirium tremens. And the first thing you want to know about this is it takes about 3 days to occur. So this is not going to occur in the first 2 days. And you'll learn this very well in your clinical rotations because if alcoholics come into the hospital, one of the things that is sometimes done is if they can be safely discharged within a day or two, you do so that they can get back to their usual drinking routine. If you keep them in the hospital for 3 or 4 or 5 days, they may enter this severe phase of alcohol withdrawal. This is the most severe manifestation of withdrawal, and in some studies, it has a 20% mortality. Delirium tremens, or the DTs as they are commonly called, get their name because patients who have this condition are delirious. They usually have markedly altered mental status. When you care for these patients in the hospital for several days while they work through the DTs, they will often be unresponsive to commands, sometimes moaning, sometimes hallucinating and talking to people who aren't there. They're also usually agitated, and they can develop a fever that can get very, very high. Drenching sweats is a classic symptom of delirium tremens. These patients will often soak right through their hospital gown when they are hospitalized. Another classic feature is autonomic hyperactivity. Basically, the autonomic nervous system gets overactive in this condition, so patients can have a significant tachycardia, sinus tachycardia in the 130s or 140s, and they can have hypertension where the systolic blood pressure can get very high, and often these patients have to go to the ICU for intravenous medications to bring their blood pressure down until they work through the DTs. And patients can die from this condition, as we said before. There are many causes of death. Some of them are hyperthermia, arrhythmias, fluid and electrolytes can get out of whack, and many, many other things can go wrong that lead to death during delirium tremens. The treatment for alcohol withdrawal is with benzodiazepines. These improve agitation and they prevent progression from the early stages into the later stages like delirium tremens. And in many hospitals, symptom trigger therapy is used. This is called a CWA scale. The word CWA stands for the Clinical Institute Withdrawal Assessment for Alcohol. So they created a scale system, which is basically a point system the nurse can determine. She can assess the patient for symptoms like tremor and sweating and things like this, and it comes up with a point score, and the nurse regularly assesses the patient, and if the point score gets too high, the nurse administers a benzodiazepine. So because of the CWA scale, you often don't have to check on your patients every 4 or 6 hours to see if they're developing withdrawal symptoms. The nurse can assess them and automatically give benzodiazepines based on the CWA scale score. So many people are aware that it's hard to quit cigarette smoking. If smokers stop smoking cigarettes, they will have cravings and often go back to smoking. What people are not always as aware of is that if you've been drinking alcohol every day for a long period of time, it is also very hard to quit drinking. First of all, when patients stop, they often develop withdrawal symptoms, and you can help your patients with those by prescribing them benzodiazepines. That will get them through the first week or so when they have symptoms like tremor and sweating and other withdrawal symptoms. After they've become clean, though, it's also hard to stay clean because many of the things that drew them to alcohol in the first place are still present in their lives. So, in this phase of treatment of alcohol, there are a couple of things you can do to help your patients. First of all, you can recommend a support group. There are many of these. The classic one is called Alcoholics Anonymous, but there are others. And then there are 3 FDA approved drugs which have been shown to reduce the risk of relapse. So, we'll talk about those in the next few slides. Those 3 drugs are disulfiram or antabuse, naltrexone, and acamprosate. Disulfiram or antabuse is a drug that I talk about in the biochemistry section. It inhibits the enzyme aldehyde dehydrogenase. If you look at the bottom of the screen, the way ethanol is metabolized in the liver is ethanol is first converted into acetaldehyde by an enzyme called alcohol dehydrogenase. The acetaldehyde is then converted into acetate by an enzyme called aldehyde dehydrogenase. Disulfiram inhibits this enzyme, so if patients drink, when they are on this drug, what will happen is levels of acetaldehyde will build up, and that makes them feel unwell. And this will discourage them from drinking because if they do, when they're taking this drug, they will feel lousy. Now, of course, the patient has to be motivated. If the patient wants to drink, they could just skip a dose of the drug. What happens when acetaldehyde accumulates is it triggers a catecholamine release. So patients develop symptoms like sweating, flushing, palpitations, nausea, and vomiting. Basically, they just feel very unwell, and hopefully that reminds them to not drink anymore. Naltrexone is another drug that is approved for alcohol abusers. It's a long-acting opioid antagonist. I talk about it in the video on opioids. The reason that this works in alcohol abuse is that there's evidence that endogenous opioids reinforce alcohol effects. So patients who take this every day are less likely to abuse alcohol and get benefits from alcohol if they do cheat. And as I said before, it's also used in opioid abuse. And the last drug for treatment of alcoholism is acamprosate. The mechanism of this drug is incompletely understood. They're unlikely to ask you about this on your board exams because we don't really know why this drug works. What is known is that it can modulate NMDA receptors, and this is believed to be part of its mechanism. The idea here is that there's evidence that alcohol disrupts equilibrium in the central nervous system between excitatory and inhibitory activity. So, excitatory activity is via the neurotransmitter glutamate and NMDA receptors. Inhibitory activity is via GABA. So the idea here is that by modulating these NMDA receptors, it somehow restores equilibrium, and that helps alcoholics to stay clean. And the most common side effect of this, really its only major side effect, is about 15% of people experience a mild diarrhea. For the remainder of this video, I will talk about some other substances besides alcohol that are also CNS depressants. And the first group of substances are the barbiturates. These are drugs like phenobarbital and pentobarbital. They are anti-seizure drugs that are sometimes used to treat patients with epilepsy. They activate GABA receptors. That's how they exert their CNS depressant effects. And many years ago, these were used as sedatives. If you were a doctor in the 1950s, you routinely gave barbiturates to patients to help calm them down if they were agitated or anxious. Now they've been largely replaced by benzodiazepines. Benzodiazepines came out in about the 1960s or 70s. And as we'll talk about later, these are much safer drugs. It's very hard to kill yourself with benzodiazepines. But in the 1940s and 50s, barbiturates were used by doctors a lot, and they were often obtained on the streets and became drugs of abuse. They have similar effects to alcohol. They are CNS depressants, but they have a narrow therapeutic index, and so it's easy to become toxic on these and accidentally kill yourself. In particular, if you take barbiturates with alcohol, that can be a deadly combination that can lead to respiratory depression and death. And if some of you are familiar with the actress Marilyn Monroe, she was a famous actress in the 1950s. She overdosed on barbiturates accidentally. That's how she died. Other famous celebrities have abused barbiturates and died from them as well. So, as I mentioned before, an overdose on barbiturates can cause respiratory depression. This can especially happen if patients drink alcohol at the same time they take barbiturates. There is no antidote. The treatment is supportive care. Sometimes these patients need mechanical ventilation. You just have to wait for the barbiturates to wash out of their system. And heavy users have to be weaned. If heavy users stopped abruptly, they can develop a withdrawal syndrome that resembles alcohol withdrawal in many ways. Patients can become delirious, hallucinate, seizures can occur, and in some cases, this can progress to cardiovascular collapse and death. Lastly, we'll talk about the benzodiazepines. These are drugs like diazepam, oxazepam, and lorazepam, and these drugs have many legitimate medical uses. For example, we've already talked about how you can use these drugs in alcohol withdrawal. They're also often used to treat anxiety. If a patient overdoses or takes an excessive amount of benzodiazepines, the classic presentation is CNS depression with normal vitals. These patients will have altered mental status, slurred speech, and ataxia, but they won't have hyper or hypotension, and they won't have tachycardia or bradycardia. Basically, what you need to remember about these drugs is that they're relatively safe. They rarely cause respiratory depression. They are safer drugs, and it's really hard to kill yourself with benzos. That's why they've replaced other drugs like barbiturates. So a patient who overdoses is basically going to look like a patient who is just drunk and completely wasted. They'll have altered mental status, slurred speech, they may have lost their balance, but they won't have abnormal vital signs, and that's because these are generally safer sedative drugs than some other sedatives. There is an antagonist to benzodiazepines. It's called flumazenil. It's an antagonist to the benzodiazepine receptor. It can be used to treat overdose of benzodiazepines, but you should know that its use is controversial. First of all, overdose has a low mortality rate. Like I told you before, it's really hard to kill yourself with benzodiazepines. And there are some reports of patients being administered flumazenil and having withdrawal seizures, which can be life threatening. So, for this reason, this drug isn't used very often, but it is available as an antagonist to overdose of benzodiazepines. If patients are chronically using benzodiazepines for a long period of time and they abruptly stop, they can develop a withdrawal syndrome. This is seen with abrupt stopping in a chronic user, and the time after stopping depends on the drug. Some benzodiazepines are long acting and have a long washout, so it'll take a long time before the patient develops withdrawal. Other benzodiazepines are shorter acting, so this is different from alcohol, where every patient develops symptoms 6 hours to a day after stopping. In benzodiazepines, it depends on which drug the patient is using. Some of the symptoms look a lot like alcohol withdrawal, things like tremor or anxiety. This is what happens when you remove a CNS depressant from the body. Many of these patients become depressed and develop a depressed mood. This is called dysphoria. Also, these patients are classically hypersensitive to sensations, so noises will seem really loud, touches will really bother them. They can develop psychosis, they can have seizures, and in some cases, this can be life threatening. And the treatment, obviously, is to give them benzodiazepines and wean them off the drug. It's only the abrupt cessation of benzodiazepine use that leads to this withdrawal syndrome. And that concludes our video on alcohol and CNS depressants.